All right, welcome everybody. Thank you so much for joining us this afternoon for today's Doctor is In program. For those of you who are new to Doctor is In, this is a monthly program that we offer through a partnership between us as the Elder Initiative at the William Wade Community Center and Jefferson Health, specifically the Jefferson Department of Family and Community Medicine. And so we offer these programs each month, bringing in doctors from Jefferson to share their knowledge and answer questions for folks in the LGBTQ community. And we've been going with this. I think I recognize many of the names who are here. So thank you for joining us. Our first program of 2023. We're very excited to get Doctor is In up and going for the new year. A couple of logistical things before we get started. At any point in the program today, you can put your questions into the chat or the Q&A. And I will, when I'm done talking here, make sure the chat is set up to take everyone's questions. I know I missed doing that the last time. When you use the chat, your name does appear. If you prefer to ask your questions anonymously, you can use the Q&A feature. And there is an option to keep your name anonymous. Our presenter today, who I'll introduce momentarily, is going to pause periodically throughout the program, and I will read off all of the questions at that point. So do not fret if I don't get to your question right away. We are going to pause, and I will be sure that we get all of your questions in. Cover questions, the chat. We are live on Facebook. If anyone is watching us on Facebook, you can put your questions in as a comment, and I will read those off for the presenter when we pause for questions as well. We are joined today by Dr. Chris Azzolino. Dr. Azzolino is a doctor at Jefferson, completing his fellowship in geriatric medicine, is a first-time presenter with us at the Doctor is In. So we're very excited to have him here presenting to us on today's topic of depression. We do, obviously, as a series with medical professionals, we're talking about this issue through a medical healthcare lens. Obviously, there are many different approaches to mental health, and Dr. Azzolino is going to cover some of those treatments today. But I'm going to turn it over to him to get us started. So big thank you and welcome to Dr. Azzolino, and you can take it away.
Well, thank you, David, for the introduction. Thank you for everyone for joining. I really appreciate it. I'm also honored to be here. So I'm going to talk about depression today. And as a background, I am originally trained in primary care. So I do a lot of, routine preventative health. I am doing some further specialization for geriatrics right now. I'm going to talk about this at the end, but I think the biggest take home, but remember one thing from this whole talk is that depression is extremely common. I see it all the time. If anyone out there is ever struggling with this or feels like they have it, please just know that a doctor is always happy to talk to you about this and always happy to talk through what we can do. So big take home, very common, and please, if you want to, a doctor is always happy to talk to you about this. Also, as a backstory, I do tend to talk fast. So I'm going to do my best to talk slow and slow it down. If anyone feels I'm talking too fast in this presentation, please put it in the chat and I will make a note to slow down. So I'm going to go through 4 discrete parts of this talk. We're going to go through epidemiology. What that means is kind of how much depression is in the population. I'm going to go through the clinical presentation, kind of what signs, what symptoms someone might have that would think they have depression. And then I'm going to go through what we as doctors do for screening and diagnosis. So what we do when someone comes to us thinking that they have depression, what do we do that would further kind of clarify that? And then we go into treatment, and treatment is about medications, it's about therapy, it's about other things. So we'll go through all of those as well. So what I'm going to do is with these 4 parts, after each part is done being spoken about, we'll pause and go through any questions that might be had throughout then. So starting with epidemiology. So epidemiology is a very fancy term. Really what this just means in our doctor language is kind of seeing how much of the population is affected by something and what the percents, what the stats are for that. So prevalence really just means how much is this common in a certain setting. So I'm going to start by just sharing some numbers, just kind of echoing how common we see depression. So 6 to 10% of patients in the primary care setting, so that's primary care, family medicine, your doctor, that's 6 to 10 out of 100 patients. It's a lot. 15% of adults actually have minor depression. So not major depression. I'll kind of talk through in detail about the difference between minor and major depression. If you're in a nursing home, it gets higher to 12 to 20%. If you're hospitalized, it gets even higher, 11 to 45%. Palliative medicine, there's other fellows that are palliative doctors. They're trained in more helping people staying comfortable, kind of discussing goals of care, end of life. So someone has, an end stage diagnosis or something, that's when someone might be in palliative medicine. So that's up to 42% could have depression, and up to 58% in patients with cancer. So before I pause, let's make sure it seems like everyone can hear me okay. I'm just making sure no one's having any difficulties with me being heard. Everything seems okay from that standpoint. I don't see anything in the Q&As about that, so it seems like all is okay.
That sounds good on my end, Chris. But yes, the chat is now open. So if anyone is having problems with the audio, you can put that in the chat and we'll try to help.
Perfect. Thank you, David. So just some fast facts about, and this is really, I'm going to make a few just pearls here and there about elderly or geriatric specific points, just because that's what I'm trained in. I know that applies to some people here as well. But so depression is actually the leading cause of disability in the elderly. One thing to know is people think that if you are old, you automatically get depressed, but no, depression is not a normal part of aging. That being said, older adults are actually less likely to come to a doctor and say, doc, I am depressed. Doc, I feel down. Can we talk about it? That is less common in the older population. And they're less likely to actually acknowledge it. They might think that it's just normal, oh, I have no hobbies, I have no friends, but this is normal. But they might not recognize that as much. And then as you get older, there's a lot of medical risk factors that make you more prone to having depression. Some being eye issues, or the fancy word we use in doctors' terms is ophthalmologic. So that could be, cataracts, glaucoma, decreased vision. And you think of some of the diseases that people get, more specifically in the elderly population, being stroke, heart disease, heart attacks. A lot of that, if you can't move your arm as well because of a stroke, or you can't walk like you used to because of a heart attack, that could make you a big risk for being depressed. I'm going to put in a quick note, and this might apply to some of you out there. I always just put in a plug for caregivers. Caregivers, in my opinion, as a geriatrician, is the hardest, most underpaid job in America. I think this is exceptionally difficult. And just a note of people that care for other people, 18% of US adults are caregivers, which is 18 out of 100, close to 20%. That is a huge number. And out of all the adults I'm talking to right now, 1 out of 3 adults will become a caregiver at some point for a loved one, a family member, a friend, or part of a job. And I often think of caregivers as the invisible patient. And depression rates in this population are almost the highest. 18 to 47% of caregivers experience depression. A lot of times, I've seen daughters or wives of patients or husbands, who are caregivers, and just how hard it is for them. So just a plug for caregivers. So medically speaking, why do we care? Why are we having this talk? Why is depression so important? So depression really does impact physical health and quality of life. If someone is depressed, they might not want to take their medications. They might not want to go exercise. They might not want to do things that normally help make them better, or make them the person that they are. And it really does complicate management of illness. If you have diabetes or heart disease and you don't want to exercise because you're depressed, you don't want to eat healthier because you're depressed, it can make that so much more difficult to manage. It also is really tough for, loved ones, dealing with someone with depression, if the loved one is working with them, it could be taking a big impact on that relationship. A bit towards the other side, it could make people want to have a premature death. It might be in your 60s, 70s, 80s, and just be ready to die instead of really experiencing the best you can in your later years of life. And then depression is associated with a greater morbidity and mortality. What that means is morbidity and mortality is chance of dying and also chance of having really bad diseases. And it makes that more increased if you have depression. So we care a lot. It impacts a lot. And it's something we can do a lot about, which we'll talk about later. So I'm going to pause here. We can hit our Q&As. I'm going to branch to our next section after this, which is about the symptoms, but we'll take a pause real quick to see.
Yeah, I'll read off the one question that came in through the Q&A, which you kind of started to just touch on with the mortality, but the question just being, can depression kill you? So can it be fatal? And I think that, could maybe be talking about death by suicide, but also as you're talking about that there is an increased risk of mortality. So is that something maybe you can just expand on a little bit or hold off on if you're going to get to it more later?
I can explain it. And I think by depression directly killing you, I think the thing I'll be most concerned about is about suicide. So about, being so depressed that you want to end your life. I would say the part about morbidity and mortality, I wouldn't say depression can directly kill you in that way. I would say it just makes your other diseases so much more worse, meaning that it's so much harder to manage if you have depression. So can't directly kill you, but by not being able to take as good of care of your other symptoms and other clinical illnesses, it indirectly will potentially kill you by that means, if that makes sense. So we're going to branch now to our symptoms that we look at. And what I will just say is a little plug for the meme I have here, but Dr. Google is always a dangerous place. Dr. Google can tell you a lot of bad things, but really my goal now is to tell you the symptoms that you might be having that might make you think that you are depressed, or maybe a loved one or a friend or a family member. So my formatting got a little thrown off here, but there is this symptoms of depression, and we remember by this phrase called SIGI caps. SIGI caps is a mnemonic we learned in medical school, and it's eight letters. Each one stands for a symptom. And when someone thinks they're depressed, these are the 8 symptoms that we look for. So SIGI caps, starting with S. S stands for sleep. If someone's depressed, you typically think of more sleep. So someone just wants to lie in bed all day, they just want to sleep because their life might be easier while they're sleeping. But also decreased sleep is also a symptom of depression. And that, in my mind, often comes from someone that is lying in bed at night. Their mind is racing. They can't, think about all the things that they want to live with, and that would just make them not be able to fall asleep at night. So that's the first thing we always ask about. The next one is interest. And this could be a lack of, which is what we typically think of, or it could be increased or decreased interest. So the fancy word that we learn in med school is anhedonia. Very fancy word. What that means is the decreased interest in doing the normal things you like to do. So if someone loves to paint or they love to run and they no longer want to do that because they're too depressed to do the things they love, that is what we call anhedonia, or a decreased interest. So that's the big thing, is really a decreased interest in the normal hobbies, things that you like to do. G stands for guilt. So guilt is, what we think of is if someone has a lot of guilt over not being a good loved one, something they might have done when they were younger, guilty over maybe substance use, or just guilty over former relationships. That is a big symptom of depression. Next one is E, and that's energy. And I often think of this as more or less for energy. So, and typically for depression, we think of less, but I'll talk more about the more part. But you think of just no energy. You can't do the things you want to do because you have no energy. You can't go out because you're just too tired. You can't go to work because you're too tired. Big symptom of depression. More energy, I wouldn't say a symptom of depression, but that might be a symptom of something else that we think of. So some examples are like bipolar disease, which we'll talk about later. But we typically think of less energy being depression. The next one is concentration, and we think of less concentration. So that being, if you just can't focus at work because you're so tired, you can't focus on conversations with people because you're just your mind is elsewhere, it's racing. You just can't think straight. You can't, have conversations. You can't remember things. As a little plug, when we're doing, memory evaluations for patients that come to us that are worried they have dementia, we actually screen for depression because this could impair concentration so much that it affects your cognition and your memory. Next one is appetite. That's A. So appetite, it could be more, it could be less. So this was really person dependent. Some people are depressed to the point where they just want to eat. You might think of like stress eating. Some people are so depressed they just can't even bother to eat because they're just so sad they don't want to enjoy a meal anymore. I've seen it both ways. It really probably goes 50% either way. The next one is P, and I'm sorry if you can, it goes psychomotor and then it's really slow or really fast. The formatting got thrown off a little bit. But by psychomotor, what this really means is that what I think about is if someone is just really, really, really slow, and that's meaning if they talk like this and they are really slow, or if they're moving really slow, they walk slow, their hand motions are slow, that could be a sign of depression as well. When I'm saying really fast, we'll talk about that later. That's more of a sign of something else, like bipolar or schizophrenia, which I'll talk about a little bit. And then the last one is S, which is suicide intent, like one of the people in the chat mentioned. Whenever someone comes to me for depression, just so you know, I always, every single time, just ask about suicide. And the reason behind that is just because I want to make sure my patients know it's always a safe place. You know, if you're feeling like that, you could always tell your doctor and make a safety plan and go through things. But that's, you know, that is something a doctor asks every time to a depressed patient. And it's not because of something they're specifically worried about. It's really just them making sure, you know, it's an open environment and something they want to ask about so that, you know, they're there for that. So talk about some disparities about these symptoms. So people that might have more depression than, you know, the average population. So specifically the LGBTQ plus population, they endorse 31% of them can endorse symptoms of depression. And up to 39% have suicide intent at some point as well. It's also a big cultural thing. So I've seen, you know, I've had some African American patients or African American doctors that I've worked with where they don't, some of them culturally don't believe in actually seeking mental health or talking about their mood or talking about that. Um, Sometimes spirituality or personal beliefs of, you know, I believe that I can deal with all I can, or I believe that God can help me through everything. Some people might think something along those lines, which can contribute to some issues. Veterans have a higher rate of depression, also of substance use, if you have formerly served in the military. And then there's some environmental factors as well. So loneliness. So if you have no one, no support system, that's a big risk factor. If you're a caregiver, like we talked about, or if you're experiencing other deaths. So as a geriatrician, this is something I specifically worry about is if someone's partner passes away, someone's parents pass away, their friends passing away, that all is a huge risk factor of developing depression. Formatting got thrown up a little again, so I apologize, but some risks for depression. We talked about some of these, but ones that I see, so poorly controlled pain. If you have a family history of depression, so your parents, your sisters, your brothers have depression, that's a risk factor. If you have hypothyroidism, that's a medical condition, but if your thyroid is low, that could be a sign of depression or a risk for depression. If you have any, you know, issues with substances or alcohol, that could be a risk. If you have end-stage renal disease, meaning if you're on dialysis or your kidneys are really bad, that could be a risk. If you have advanced stages of illness, if you know, if you have minimal support, if you're lonely, if you're physically impaired, you're handicapped, you can't walk well, you're limited by such pain. If you have cancer, some people also have spiritual pain, which might be where they feel like something about them is just wrong with what they believe the higher, you know, the way that God would view them, or they view that they've done something so wrong or something so unforgivable in the past. That could really be a risk for depression. And then a prior suicide attempt, if someone ever tried to hurt themselves in the past, that is actually the biggest risk of having future depression and also a future suicide attempt. So I'm going to pause here going to my next part. This is screening and diagnosis, but I'll pause. I see there's a question in there that I think there is that we could hit, or it might not be.
Yep. The question that came in was related to, I guess, to heart health, to heart attack specifically. So are there links between depression and I think this is asking about risk of heart attack?
Yeah, and I think this goes both ways. So I would say there's a question of, does the heart attack cause depression or does the depression cause the heart attack? So talk about both of those. And I think both are correct. So I'll start with heart attack causing depression. So if you have a heart attack, you could be seeing a cardiologist every 3 months. You could be on 5 new medications. You could not be able to exercise like you used to. It could really have a lot of impacts on your life. And I could definitely see how that could cause depression. The vice versa of depression causing a heart attack, I also think is possible. And by that, I would say if someone is so down that they're, using substances like cocaine or heroin or what that could cause risk, especially cocaine. If someone's down to the point where they're not exercising, they're not eating well, they're not taking care of themselves, they're not taking their medications like a statin, like Lipitor or Crestor that they should be on, or their baby aspirin that they should be on, that could also be a risk for a heart attack. So I think it comes both ways of, being so down you can't take care of yourself, causing a heart attack, or the heart attack making you down where you can't take care of yourself and you're depressed. So I'm going to move on to the next part, which is
actually, I just had another question that just came in, which is a good timely one. So when talking about suicide as a risk factor, and I didn't mean to say at the beginning, just a recognition that like some of these things can be difficult to talk about, and so just wanted to, I think people realize that, but did just want to acknowledge that we know that these are sensitive issues to talk about, especially when we get into suicide. The question that came in though was, does the risk of suicide become less, the longer time away from a prior attempt is? Does that make sense?
Yes, and I would say it does. So I would say if you, and also thank you, David, for just clarifying that. Everything I'm talking about today is very sensitive information. So I appreciate you just making that plug. So what I would say is, the highest chances of having a repeat suicide attempt would probably be, or depression would be immediately after. You are after the event, you realize all that happened, you realize, how much your life has changed. And afterwards, I would say if you have proper treatment, meaning you go to therapy, meaning you are on the right medications, you have close follow-up with your doctors, that chance does diminish over time as we get further and further away. And I would say that really just comes down to, taking care of yourself and also just knowing that you're doing all the right things to get further and further away from that. And people change over time. I'm a very different person now than I was when I'm 15. I think for a lot of you, that's also true. So I would just say people change over time. The farther you are away, I would say as long as continuing to change for moving yourself to a better you and one that you're more comfortable with and more, I think that would definitely decrease that over time.
Thanks.
So in my opinion, as a primary care doctor, I think every single person that walks in has to get screened. So if you ever walk into a doctor's office, they'll often do this thing called a PHQ-2 for you. A PHQ-2, it stands for Patient Health Questionnaire, and then 2 stands for it being 2 questions. And this is the reason everyone should get screened is because remembering the prevalence, how common it is that we should always just ask people about these symptoms, because sometimes people don't want to share that they may have these symptoms, but sometimes opening up with a quick screen might actually get the ball rolling of someone saying, I actually think it's a comfortable place to talk about these with my doctor today. Is the reason why doctors will often do this. So there's 2 questions. The first one is about that fancy word we learned before called anhedonia. So this is just asking, in the past 2 weeks, have you had any little interest or pleasure in doing things you normally like to do? And it kind of goes from a not at all, a 0, to a 1 being several days, a 2 being more than half the days a week, and the 3 being every day of the week I'm feeling like this. The second question is, have you ever been feeling down, depressed, or hopeless the last 2 weeks? Similar, it's on the 0 to 3 scale. And really, the reason we do this, Shrina, is if you score a 0, meaning you say not at all to both questions, that is a very strong screening test saying that you likely don't have depression, if you can answer no to those 2 questions. If you answer anything but no, that usually will prompt us to have a further discussion about these 2, about mood, depression, and such. So this is the screening test that often gets done. This is usually done by the nurse or the medical assistant when you first walk into a doctor's office. So this is something I'll talk a little bit later about this. I want to just kind of throw out, there's many different types of depression, and we often call this thing called the mood spectrum. So for depression specifically, we have major depression, which is what we think of when people are really, really down. We think of minor depression, which is very common in the population. And I'll talk about those two in more detail, as well as dysthymia, which is a fancy term, which I'll talk about also later on. But dysthymia is really just a very, very long version of minor depression that lasts for years. Now, I just want to point out something called the mood spectrum. In talking to a lot of psychiatrists in the hospital and medical career, is they often believe a lot of this with depression, mild depression, bipolar, we think of hypomania, mania, which I'll talk about. It's all on a spectrum. So no one is just bipolar or not. No one's depressed or not. It's a spectrum where we're kind of towards one side of it, which is I just want to make sure I show this image. I'm going to talk about all of these in more detail. I'm going to focus on the depression piece, but I just want to make a few bullet points later on about what we think of when we think of bipolar and some of those other things, especially because a lot of my patients, just as an educational piece, there's a lot of, I think, in my opinion, a lot of misunderstanding of what the word bipolar means. People might say, oh, they're nice one minute, they're mean the next, they must be bipolar or something like that. And that's not what it means. So I want to make sure when I get to that, I really can do education piece about what this actually means and what we look out for. And people with bipolar actually do suffer from depression, which is why I also wanted to bring it up later on. So I'm going to talk about how we diagnose major depression. So to have major depression, you have to have a depressed mood. And then we think of 4 additional symptoms. So if you remember before, we talked about the Siggy Caps mnemonic, all those 8 symptoms of depression. If you have the depressed mood plus 4 of those for 2 weeks, then we could diagnose it as major depression. That's what we think of when someone comes to us. Whereas minor depression, which we talked about, you have the depressed mood, but you have 2 symptoms of the Siggy Caps. So major depression, you have 4 symptoms of that. Minor depression, you have 2 of them. And both of these are for a 2 weeks duration. So people could be down for a day or 2. That would not constitute depression. It has to be for 2 weeks to have these symptoms. Dysthymia is the other one we talked about. And when I think of dysthymia, I think of a super, super long minor depression. So the way we describe it as doctors is that this is minor depression. So we talked about those symptoms before, where you have the depressed mood and the 2 additional Siggy Cap symptoms. So you have that for 2 years, and then they're continuous at least for 2 months at a time. So the way I think of that is that if you have 2 months of feeling like you have minor depression, and then it can happen again 2 months later on, maybe take a few months off and come back in 2 months, and it's continuously present for 2 years, then we think of this. And this is just a persistently down mood is how I describe it to my patients. You're not depressed, you're still functioning, but you're just persistently down, and you may have some struggles with a lot of parts of life. Now, from a diagnosis standpoint, the gold standard that we do is the PHQ-9. So I talked about the PHQ-2 first. PHQ-9 stands for the Patient Health Questionnaire. 9 is because this is 9 questions long, or 9 parts long. So if you're ever seeing a doctor for depression, this is the screening test that they should be doing with you. And if you look at these questions, it's actually, there's 9 parts of it, and they're actually the exact same questions as Siggy Caps that we talked about before. So you see little interest, so that's the I in Siggy Caps. You see the trouble falling or staying asleep or sleeping too much, that's the S. Tired, that's the energy part of Siggy Caps. Appetite, that's the A part of Siggy Caps. You can see concentration, which we talked about, the C in Siggy Caps, speaking so slowly or moving so slowly. That's the P in Siggy Caps, the psychomotor part. And then, like we talked about, the S, the suicide part of it as well. So many of these overlap. So this PHQ-9 really is taking that Siggy Caps mnemonic and putting it into a screening test that we can use as doctors. Now, for each question, kind of similar to the PHQ-2, you answer on a 0 to 3 spectrum. So the 0 being, I have none of these symptoms the last 2 weeks. The 1 being, I feel these maybe several days, maybe 1 or 2 days of the week. A 2 being, you feel it more than half the days of the week. And a 3 being, you feel these every day. So I have an example patient on here, and you can see how they checked it. So you add up the score of all of the questions that they get. And this kind of will go into the next part where you can see how the score, it kind of breaks down on where you are at on the depression scale. So a PHQ-2, and I apologize, it's a little blurry. A 0 to 4 means that we are okay or have minimal depression. Now, that being said, I'll put a plug in that these tests are not perfect. If you score 0 to 4, but you still feel like you are depressed, that does not mean you are not depressed. Tests are not perfect. This is just a tool that we have. I want to make sure I put a plug out there that if you still score negatively for this or normal, you could still have it. This is what you're feeling, because what you're feeling is actually the most important part of everything, regardless of this. This is just a tool that we have as doctors. 5 to 9 is what we think of as like what we will see for most of our patients, and that is a mild depression. And really the recommendation of this, you can see it has the proposed treatment to the next side of this. Proposed mild depression, we often think of, you could do some therapy, or you could maybe consider a medication, but you don't need a medication. I'll talk about this later on. I am a firm believer that every single person, regardless of depression or not, should see a therapist. I think therapy is an amazing tool. So I just want to put a plug out for that. But this does recommend a 5 to 9. You should maybe consider seeing a therapist. 10 to 14 is what we think of a moderate depression. And now this is where we get a little more concerned about, maybe we should see you again in 2 to 3 or 4 weeks. We should see you back. We can review a treatment plan, talk about things very closely, have close follow-up, discuss medications, discuss therapy. I'll talk about this later on too. I've never wanted to push medications. I'll push therapy a little bit, but medications, I always have a pros and cons discussions with patients about. But I don't think anyone should ever feel like they have to start a medication based on their symptoms. That being said, I always think it's fair to talk about the pros and cons of these. I'll talk about this later on. 15 to 19 is where we get moderately severe depression. And that is, we get very worried. We really want to see you back in a week or a few days. We really would probably actually push starting a medication. A 20 to a 27 is very worried. This is when you see me, I might say, I think we actually might need to go to the hospital to get potentially psychiatric medicine to see you. That's when I'm very worried. And I would talk to you about, I am concerned, and I really, would be very worried about that person. And that might be having a pros and cons about going to like an inpatient psychiatric unit, possibly. That's where we get very worried. We use this more in the geriatric population. There's something called the geriatric depression scale. That's another version of this test. I won't go through it in as much detail as the PHQ-9, but the geriatric depression scale tends to be a better test if you are 65 plus. The reason behind this is that there's actually some studies saying this actually works better for patients that might have any bit of cognitive impairment like dementia. This is actually because it's a yes or a no. So it's 15 questions long and you just answer yes or no. So it's much easier for patients instead of saying, I think I'm a 2, I think I'm a 3, I think I'm a 0. It's just a yes or a no question. That being said, there are some downsides. There's no questions about sleep. There's no questions about suicide. There's no questions about somatic symptoms. Somatic symptoms being those feelings of being slow or talking slow. And it doesn't give us as much guidelines for treatment. The PHQ-9 gives us this very clear guideline of where you fall and what we can do. Whereas the geriatric depression scale is just if you score a 6 out of 15 or higher for the positive answers, then that is a yes for depression. So this is what it looks like. I'm not going to go through as much detail, but you can just see it's a yes or a no question. You can see it. I'll let you take a look at this for a few minutes just to read while I'm talking. But it has a lot of similar questions to the PHQ-9. I also, when I'm talking to patients about this test, I will often say this is a very hard test to think about. These are very intrusive questions. They can make you also provoke a lot of feelings. So I always start by starting them before I ever do this. Also, most patients I talk to, they usually have a hard time giving a yes or a no answer. It's usually much more of a gray scale. So, do you often feel helpless, for example, number 8? I'll have someone say, I felt helpless last week, but I feel fine today, but I really can't answer that question straight, which is a really hard thing for a lot of patients that they just want to. That's why the PHQ-9 is a little easier because it's all of a scale of 0 to 3. It's just harder for some patients to be able to kind of understand that sometimes, and it takes a lot more time. So like I said, this is 15 questions. They're yes or no's over 5. So if you're 6 or above, that would indicate depression. So those are the big 2 tests that we use as providers, the geriatric depression scale, and also the PHQ-9. And we don't do those for everybody. We more do them if we have a reason to do them. The PHQ-2 is the one we do for everybody as a screening test. So I just want to take a few moments. I'm not going to spend most of the time talking about this. I just wanted to make sure a quick educational piece while I had the moment is talking about bipolar. And bipolar, we worry about something called mania. So mania, what I think of is if you have a decreased need for sleep, you are sleeping an hour a night, you have a higher sex drive, much more than your baseline. You're talking very pressured, very fast, talking as fast as like this, something like that we think of. You're feeling on top of the world. We call that euphoria. You feel like nothing can stop you. You're doing risky behaviors. You're spending money. And then you have higher energy levels. You're just not sleeping. That's what we think of as like a bipolar of the mania specifically. We don't think of the mood swings, more of swings in this regard of going from the highs to the lows. Now, bipolar 2 is more of something called hypomania. And these, more of just, you think of a less extreme version of the mania. So you think of being irritable, being excited, a little aggressive, restless, distractible, talking really fast, not sleeping well. These are actually, to be honest, actually some of the most high functioning people because they are the ones that can go a million miles an hour at work and then sleep for 4 hours and do it again the next day. The problem is a lot of these come up to lows, which is bipolar 1 is when you have the mania and you have depression, whereas type 2, you have the depression with the hypomania. I'm sorry, so type 1, you have the manic symptoms. You can go from normal to manic. Type 2, you have depression, and then you also have the hypomania. So they have those swings. Just as a quick note, mania causes more hospitalizations for patients. Depression will cause more disability, is a quick thing. And bipolar is often a strong family history. A lot of times if a parent or a sister or a brother has it, oftentimes family members often might as well. So this is now transitioning back to back to depression. And a lot of patients come to me, I feel depressed, should I get blood work done? And the answer is yes or no, or maybe. The big things I look at is, maybe looking at a metabolic panel, thinking of someone's blood sugars, making sure they're not undiagnosed diabetic, looking at their electrolytes, looking at their kidney function. We might look at a complete blood cell count, looking at anemia, if your blood counts are really low or have an infection, and then maybe a thyroid level. And then with the electrolytes, like we talked about, that's more of looking for like adrenal issues or things like that. So what I typically do is I don't do it unless someone has specific symptoms of a medical condition that I'm specifically worried about, and then I'll do blood work. But I don't do it routinely for everybody. I'll put a quick note on psychotic depression, just so you know. This is what I think of as depression with delusions, hallucinations. You might have fixed or false beliefs. So it's not where you have the mania or the hypomania. It's more of you have these like fixed concerns of, I'm convinced my partner is cheating on me, or I'm convinced of, something else, or I hear voices and I'm also depressed. That's what we think of. And I'm not going to go into the full diagnosis of this, just more of a quick point about this. And you often see those psychomotor symptoms we talked about, being very sped up or being very slowed down in your speech, fast or slow in your movements, which is what we asked that in that PHQ-9 and the SIGI caps with the P for psychomotor. So as a disclaimer, like we said, suicide always hard to talk about and always a sensitive subject. Just as a point, as to make sure you all know, if anyone out there is ever feeling like this, please, as a doctor, I will never turn a patient away from me who is concerned about this. So please, speaking with other doctors, talk to a doctor or even talk to a loved one about this. Some just quick bullet points. Firearms are what we learn is the most common way of completing suicide. So you have a gun in the house. That is the most common, or something we personally worry about from a suicide perspective. And we talked about this a little bit before, but the biggest risk of suicide, or if you had an attempt in the past, is the #1 risk of having a future attempt. A lot of the other symptoms, so recent losses, hopelessness, substance use, perceived burden on others. I just think I am a huge issue for everyone around me, or impulsive behaviors, meaning you're spending lots of money or risky sexual behavior or something like that. This is the last point. I'm going to switch to treatment. I'm going to let David take it off if there's any questions I can answer.
There's nothing that has come in right now, but if folks that did have questions on any of those screening diagnostic guidelines, please put those in the Q&A and chat.
And if anything else for that comes in, I can talk about it at the end too, if anything trickles in.
Absolutely. So yes, let's do that. Go on to the next section. And if there are questions that come in, we'll get to them at the end.
Perfect. So I'm talking about treatment now. And my biggest take home of treatment is that 1 + 1 = 3. So what I mean by this is that the one I think of therapy and the other one I think of medications. So we actually learned that medications plus therapy work together. They're synergistic off one another, and they actually together help more than one alone. So it's like the synergistic effect of, you're seeing a therapist, you're doing all the right things, you're exercising, you're doing your hobbies, you're having the social support, and you're on a medication. They together work so much better together than just doing one or the other. But that being said, I'm going to go through all the different parts of what we can focus on. So I'm going to put a bullet for therapy. And this is my only slide on therapy. And what I want you to take home is that there are so many different kinds of therapy. When someone says I'm going to therapy, it is not just talk. There are thousands of types. And there are some you can see here. The big one we think of is behavior therapy. That might be a CBT therapist, cognitive behavioral. And that's really focusing on helping people reframe their mind. So that being an example I often think of is someone that has OCD, and it's helping people reframe their mindset over their OCD behaviors, as an example. But that often helps if people have this perceived fixed thing that they have in the past that's causing a lot of their depressive symptoms. The behavior therapy helps take that previous experience, and it can adapt it to the future and help you give the tools to change that in the future. But my just bold on therapy, I always just say therapy is so important. I think that anybody or everyone should see a therapist, and I will often request that my patients see a therapist. And that is not, the other thing that patients will often say to me is, I saw a therapist in the past, it didn't do anything. Not all therapists are created equal. They are very different. It's a humanistic experience. So my advice is always just to try a different one if they didn't like it in the past. That being said, if someone said, I wouldn't want to do therapy, I know it's not for me, I will not push that. But I do really think therapy is probably the biggest way. And I think this is, if I had to pick medications or therapy, I would pick therapy for my patients. I think that is less side effects, and it is really getting at the cause of someone's depressive symptoms, and really helping people understand their prior mindset and behaviors and helping that adapt and giving them tools to fix that in the future. So I think therapy is so important. Other alternatives, and this is just stuff that I often will talk about with my patients. Mindfulness is so important. So that might be stuff like meditation or just making the behaviors or really making the energy to get enough sleep, to have a work-life balance. Exercise, I think, is so important, whether it's going for a run, going for a gym, going to exercise classes, going for a spin bike ride, doing Peloton. I think exercise really, and I'm that big fitness proponent myself, I think it is so important for patients, especially with depressive symptoms, because the endorphins you get when you're exercising are so important that they really make people feel significantly better. And if someone exercises, they feel like they accomplished something that day. You can do it in social groups. You feel fitter, you look fitter. It's just such a positive cycle. I really think helps. Family and friends, if they are, having your social support, I think is very important. Talking to people, having someone you can go to that's not a therapist is very helpful, and just staying busy and doing things. So that's going to restaurants, going out to the bar, going to your social groups, going to, whatever. I think that is so important about staying busy. And I always tell my patients, in my opinion, the most important thing is that you keep on doing the things that make you you. If you are depressed, you don't shut those things out of your life. You don't shut your friends out of your life. You keep doing that, and that'll make you feel better. I think depression really spirals down is where you stop doing your hobbies, you shut people out of your life, and then it gets worse and worse and worse. So I tell them, keep doing the things that make you the person that you are. And, we can do the things to get through this. And then there's support groups. There's, and there's also, AA, there's NA, there's a lot of other groups. And there's also groups for people that lost a loved one. There's groups for people that were veterans. There's thousands of support groups out there. And this, I actually think this is helpful because they make people realize they are not alone. This is a common thing. Other people have it too. So I'm not going to go in huge detail about this. I'm just going to say some terms just so if you're ever talking to a doctor, you know what they're talking about. I'm not going to go through the pharmacology, the mechanisms. I just want you to know the terms that we often think of. So a lot of different kinds of medications. The ones that are the gold standard are SSRIs. That stands for selective serotonin reuptake inhibitors. Fancy way of just saying it gives you more serotonin in your brain and in your bloodstream. This is the most common if you've ever heard of Lexapro or Zoloft or Celexa or Prozac. Those are all SSRIs. SNRIs, very similar to SSRIs. They stand for serotonin and norepinephrine reuptake inhibitors. These ones are duloxetine, Cymbalta, Effexor, venlafaxine are the fancy terms. Very similar to the SSRIs. They're probably the most common that we see. There's TCAs, that stands for tricyclic antidepressants, and that might be like amitriptyline or nortriptyline. We really don't use these anymore. They were more old school, but we really stopped. They have a lot of side effects, especially in the geriatric population. And other ones, just so you've heard of them, aripiprazole is or Abilify is the other name. We often will use that for patients that have some, that depression of psychosis, or someone that we might be worried might have some bipolar symptoms of mania or hypomania, is they'll more go towards that end. There's Wellbutrin or bupropion, and then there's Remeron or mirtazapine. So just as so this is SSRIs like we talked about, Lexapro, Zoloft, and just so you're aware, side effects, we think of, like most medications, any kind of GI symptoms like nausea, vomiting, cramps, diarrhea. That, to be honest, is common in almost any medication we prescribe. The big ones I tell my patients about are about tremor or shakiness it could cause for some patients. It's rare, but it does happen. And this one I tell every single patient, there is actually a pretty significant risk of having decreased libido and some sexual dysfunction. So there's usually no issue, and this is, there's no issue in actually having an erection, but people have issues with having the libido being down, or actually ejaculating is a big issue. Some people will actually abuse the medications for this reason, because they feel like they last so much longer with the medication. And then for females, I find they don't like this as much because they feel like they have such a difficulty having an orgasm when they're having sex. So that's something I always make sure all my patients always know. Some patients don't notice it, but some do. So I always make sure they know about that side effect. SNRIs, we talked about these. The big take home I want to say for these, and these are Cymbalta, Effexor, like Trintellix, is you should never stop these cold turkey. They can cause withdrawal side effects, and that's because of that norepinephrine component to them. But they have similar side effects to the SSRI medications. They also have that sexual dysfunction as well. We talk about the tricyclic antidepressants. We talk about nortriptyline, amitriptyline. Really, my take home is that we should not use these in the elderly. These are really more for younger patients. We'll use it more for actually pain symptoms like fibromyalgia or some nerve pain, but really we should not be using these. You can see confusion, seizures, heart arrhythmias. They're anticholinergic, meaning like they're like Benadryl, where they can cause dry mouth, constipation, confusion. So we really try to avoid these, but you might have heard of them before, which is why I'm just trying to make sure everyone knows. And then the other ones, we talked about Abilify with the hallucinations and those manic, hypomanic behaviors. I'm going to do a quick bullet on Wellbutrin and Remeron. Wellbutrin is actually the best one that we have for weight loss. It helps people lose weight. It also helps with any kind of addictive behaviors. So it helps people quitting smoking or less alcohol use or less substance use. The biggest issue in mind about Wellbutrin is it is only good for depression. It is not good for anxiety. So it is activating in nature. It gives people a big kick. But if you have anxiety, I find nice puts people a little bit into overdrive and makes them actually more anxious. Remeron or mirtazapine we use a lot in the elderly. This gives you more energy. The reason it's good in the elderly is it helps with sleep and it increases appetite. So it kind of works well if I think of like someone that isn't sleeping well, isn't eating. It gives them a little boost and it really helps them eat better, helps them sleep better. That being said, it's not as great of an antidepressant as the SSRIs, meaning Lexapro, Zoloft, Celexa. So, those are the go-tos. I think those are the safest. Those are the ones I usually push for my patients are these ones, the SSRIs. I think they're the safest. It's really just about that sexual dysfunction I always tell patients about. So other major side effects, just so you've heard about it, I have seen one patient in my life with this. Serotonin syndrome is a side effect because all of these cause you to have more serotonin. And really the take home I have is you will not get this unless you overdose on the medication or unless you are combining different of these together. So if you're taking Zoloft and you're taking Lexapro, and you're taking a tricyclic, that could cause this, which so if patients are overdosing, that's something we often worry about. But you will not get this just from taking the medication alone as the doctor prescribed for you. And this is, you just think of confusion, activity, restlessness, sweating, diarrhea, increasing reflexes. So, you hit your knee and it flies off the table. Rhabdomyolysis, because of all the shaking, your muscles could break down, making you have some issues as well. So just something to be aware of, and really why we worry about mixing these medications together and always just doing it as the doctor prescribes. We talked about this already, but this is just the treatment guidelines. And I always say a PHQ-9 of 10 plus, I will often offer a medication to a patient. If it's a 5 to 9, I'll always recommend therapy and then maybe a medication. I will often just feel out about how they're feeling, if they want about it, and talking about the side effects. The way I describe the SSRIs to patients, the Zoloft, the Lexapro, is that they just kind of take all the stress coming down on life and they just turn it down a notch, making them just feel a little bit better. And the idea is that you don't take these medications when you're feeling anxious, when you're feeling down. You take it every single day, and it changes your baseline of how you're feeling. It gives you a little more energy and makes you feel a little less of life coming down on you, is how I describe it. Now, of all these medications, I always recommend, typically seeing every 4 weeks when they're starting or changing a dose, and then you kind of space that out over time. I'm wrapping up here, but there's a rule of thirds I want to make a point about. And this is just that if you're starting medication, 1/3 of patients will have a positive response to treatment and do better. 1/3 of patients will have no response at all and maybe need a different medication or need to do therapy or other aspects. And 1/3 will have a partial response, meaning that they are feeling a little better, but not great. And I'm just putting questions that I often get from patients. So if I start this, do I have to take it forever? And my answer is no, but maybe. So I always recommend, if someone starts it, I always say it's getting you through this phase of your life. And that I often like to say that if they're feeling like $1,000,000, I recommend they stay on that medication for another 6 months and then stop it. The idea being that you maintain being on it when you're feeling normal and then you stop it after. That really prevents relapse, because I don't want you to take it, feel great, stop it, and then you feel depressed again and you go back on it. Like we talked about, these medications should not be stopped cold turkey. They should usually be tapered down. So if you ever want to stop it, just talk to your doctor, is my take home. And then the biggest thing is if you have relapses, so you take it, you stop it, you relapse with depression, you start it again, that's where we think if you might need to be on this medication for a long time. But if you're not having relapses, then really it's just, we think of 6 months after. But the more relapses you have, and that kind of to show you're not doing well off of it, you might need to be on it for years, maybe for life, to be honest. That's a question about later on, which impossible to answer now, but something just to know. So that is all I have. I just have 2 quotes on here, and really the first one is, it's okay if healing takes longer than expected. This takes time. This is a lot of, in my opinion, depression is a systemic issue of the way that cultural beliefs are now, and that this takes time, this takes work, and it is not something you're going to fix in 5 minutes or even 5 days. This takes months, sometimes years, for people to really help get through. So just know that it's not a day by day, maybe not a week by week, but I would view a month by month scenario where this takes time to get better. And the best thing you can do is just keep making the steps every day to make you better you, and feel better. And the other quote is, I found that with depression, one of the most important things you can realize is that you're not alone. So please, everyone out there, just know that you are not alone if you're feeling depressed. Extremely common. I see it in a lot of patients. It's probably honestly just as common as me seeing a patient for blood pressure. So just know this is very common. This is not necessarily a problem with you. I think there's so many cultural things that are making this more prevalent nowadays. But just knowing that it's common, you're not alone. We can handle this. We have things we can do to help you. So I appreciate all of your time. That is all I have. I'll give it to David for any last questions we can answer.
Yeah, thank you so much. And love both those quotes. One question I think on the slide before this, is there risk of long-term, if we're talking about an SSRI or NRI for 10, 20 plus years, is there a long-term risk of that?
I would say from a long-term standpoint, I would say no. I would say, the risks of being on one for, for 3 months versus 3 years or even like 30 years, it's still the same side effects. Things don't change. They're gonna have new side effects for being on it for longer. My biggest thing I think about though is if you're on it for that long, is that just understanding it might be hard to come off it. It might be
Mhm.
something that you might be on for the rest of your life, or it might be something you just really need. If you ever are feeling well, you can maybe taper the medication by cutting it in half and doing a lower dose. But I would say that's the biggest thing I would think about is just you'd be on it. You'd be more likely to be on it for an extended period of time if you've been on it. But there's no side effects, especially if it's helping you and you're feeling well.
Question that came in the Q&A, which I'll read off. In a medical world, which has medical records that are shared by everyone in more than one medical system, how do you handle information which your patient does not want shared with others?
That's a great point. So when I'm specifically talking to a patient about depression and we're talking, I usually by default am typing. So if I'm doing a visit for blood pressure, I'm usually documenting. That being said, when it is extremely important information to a person, so if someone's talking about this childhood trauma or whatnot, I will always ask, do you want this in your medical record or no? Is
Mhm.
what I will do. And there's no clear cut triggering point where I say this is something that needs to do that. I really just endorse open communication and making sure in the beginning of the visit, I'll often just say, like, I understand, like, we're gonna be talking about some really, you know, confidential, deep down, sensitive information. If we're talking about anything that you feel is not appropriate for your medical record, please tell me. So I want you all to know that you can tell your doctor, I don't want this in my medical record, and they should, in my opinion, they should honor that wish.
It's a great point. Question that just came in. Is there a specific form of therapy that you would recommend for attachment trauma?
Ooh. So I would say, I think that's hmm, I would probably say, I'm not a psychiatrist, to be honest. I would usually recommend CBT, the cognitive behavioral therapy. The reason I say that specifically is that is the kind of therapy that is really focused on taking some sort of way that someone's mind is fixed. So someone's mind is focused on this one thing. CBT works so well because it takes the way your mind thinks and it tries to help you readapt that to think for the future and gives you skills and techniques to kind of deal with the way your mind is focused. There's also, I'm not sure, but there's also grief counseling. So if someone had like attachment trauma, I'm not sure the specific situation, but I'll just say that if someone had a really bad relationship in the past and it really just changed the way they think in the future, there's also, grief or trauma counseling as well. That's also specifically for a really bad prior experience, helping someone kind of help for the future. So those are the two I'd probably put a plug in for. To be honest, whenever someone says about seeing a therapist, I usually say, in my opinion, the best therapist you can see is the one that you like. If
Yeah,
you have a good relationship with a psychotherapist, but not the CBT therapist, see the psychotherapist you really like and have productive conversations with. Because in the end, the therapeutic aspect is not necessarily how they're trained. It's really just the relationship you two have. And if you can be vulnerable with that person, I think that is far more important than seeing a different therapist.
that's a great point. And we honestly say that about doctors also, that you don't have to, uh, you know, stick with the first person that you see if they're not the right fit for you. And it's really about finding the right fit. That's totally true in mental health services as well.
Yep, completely agree.
Dr. Azzolino, thank you so much for joining us today, for being part of our Doctors in series. This was such a great wealth of information and resources. And I think we can leave it there as we are at our time. But thank you everyone who joined us for today's program, either here on Zoom or if you're watching the recording later. We appreciate you all being part of this program series. And I'll leave it to you, Dr. Azzolino, if you have any last closing words.
I just wanted to thank you all for your time. Thank you, David, for having me. And like I just said before, please just know that depression is common. Please, if you are feeling it, you're always welcome to talk to a doctor or talk to, I just want everyone to remember it is very difficult, and it is something I see a ton of, and there's a lot we can do about it. So please, if you're feeling like it, a doctor should always be an open environment where you can talk to someone about it.